pediatric respirology and experimental medicine. She has been the lead for these gene therapy trials, and importantly, recently involved with a lot of immunomodulators work. Her research interests are in cystic fibrosis, looking at the trials of new therapies, airway infection, and inflammation. Jane is going to talk about exciting development in cystic fibrosis.
Hello everybody, I'm Jane Davies. Thank you very much to Atul Gupta and the organisers of this year's John Price Conference for enabling this virtual presentation, and thank you very much to all of those who are taking part. This is a bit of a first for me, so apologies if it doesn't go completely smoothly, but I'm hoping in the next half hour to talk to you about some of the very exciting advances in cystic fibrosis, and particularly around highly effective CFTR modulator treatments. I'll be talking about a number of new drugs, largely those currently produced by Vertex, and for these companies I've held various leadership or advisory roles, also together with physiology colleagues from the Brompton Hospital and Imperial College. We lead the European CF Society's Lung Clearance Index core facilities, which we'll be discussing later. Here's a blow-up of the cell to show the production and function of the cystic fibrosis transmembrane conductance regulator. Having been transcribed in the nucleus and then translated on the ribosome, CFTR passes through a number of intracellular organelles, which leads to its correct folding and glycosylation and transport up to the cell surface. Once here, it functions as an ion channel of negatively charged ions such as chloride and bicarbonate, and is closely involved in the regulation of its neighbouring channel, the epithelial sodium channel, or ENaC. We'll now look in a little more detail at how the different types of genetic mutations can impact the function and the presence within the cell of the CFTR protein.
Hi there, everybody. Have noticed that apparently the sound is not coming through very well, so I'm going to reshare from that particular slide in a slightly different way. So please stand by while I just try and correct the sound. Bear with me.
%, of mutations worldwide, which lead to a premature stop mutation and no full-length CFTR being made at all. The commonest type of mutation is that which leads to a misfolding defect in CFTR. F508 is the commonest example of these. The protein fails to fold up correctly, it doesn't receive its full burden of sugars, and it fails to traffic up to the cell surface. What's important is that all of the other mutations which occur lead to some, and indeed when these drugs were first being developed, this was the low-hanging fruit, and the gating mutations which failed to open upon instruction were those which were first tackled with small molecule CFTR modulators. This is a figure showing one of these gating mutations where the protein is present on the cell surface but fails to open. When a potentiator drug binds to that channel, it forces it to open, and chloride can be released onto the cell surface. Ivacaftor was, of course, the first of these to be developed, and these data, which are 8 years old now, will be familiar, I think, to many of you, but I think they're very useful to set the scene as to the sort of improvements in CFTR function and clinical benefit that can be achieved by harnessing CFTR function. So this was patients with a single copy or 2 copies of G551D mutation, This is a so-called Celtic mutation, gating mutation that fails to open in response to intracellular signals. And probably worth pointing out that these drugs are all given by mouth, so systemically, so they have the opportunity to work not only on the lungs, but also in other organs affected by CFTR dysfunction. In the first graph on the top left, we can see change in sweat chloride in response to this drug, with the placebo in the grey and the treated group in the blue. There was a very substantial drop in this biomarker in response to treatment, with mean values below the 60 millimole cutoff that's used for the diagnosis. In parallel, there were acute and sustained increases in FEV1, which was the primary outcome of this study. Bottom left, you can see the proportion of patients experiencing pulmonary exacerbations, which was significantly reduced, and bottom right, improvements in weight. These very impactful outcomes were, of course, really useful in the context of a trial and gave us a lot of hope that we could generate highly effective drugs. But I think what most of you would appreciate is what matters to the patients is the longer-term outcomes. I'm going to use this really good paper here to illustrate a number of these longer-term outcomes with data from both the US registry and our own UK CF patient registry. I'll show you first of all the exacerbation frequency, and both of these graphs are very similar. On the left we have here the US data, and on the right will be the UK data presently. The group receiving ivacaftor through clinical prescription is shown in grey bars, and the comparator group was a group of patients without this mutation but with F508del, who were matched as much as possible for the patients on ivacaftor at baseline. So over to the far left, at baseline in 2011, the number of patients, or the proportion of patients with pulmonary exacerbations, were really pretty similar. And as we progress through the subsequent 5 years, you can see that the gap between those two groups begins to widen. So by the end of 5 years exposure to treatment, there are a lot more patients having exacerbations in the control comparator group than there are in the ivacaftor group. And this data is mirrored very, very closely, as you can see, with somewhat smaller numbers here in the UK over on the right. In terms of lung function decline measured by FEV1, we see similar impacts on the left, the US data, and on the right, the UK, with similar baselines, but then a gap occurring quite soon after treatment was initiated. But I think you can probably see from both of these curves that there is also something of a slowing of loss of lung function over that time period. And this has also translated into significant improvements in survival and the need for transplantation. I think the clinical benefits of ivacaftor for this population are very clear, therefore, both acutely and in the longer term. The problem with this approach is that it is only suitable for a minority of patients as a single agent drug, probably somewhere in the region of 5 to 6% globally. And this pie chart shows the reason for that. This is the prevalence of the 25 most common CFTR mutations in the US population a couple of years ago. And at the top in the white, you can see the G551D population making up just over 4% of those. So it would be these patients plus a small number of other rarer mutations who would be suitable for ivacaftor as a monotherapy. By far the biggest issue is F508del. You can see here, present in 85% of people who are either homozygous or heterozygous for this mutation. So this really is where we need to create some big impact if we want to generate improvements for the whole population. Probably better tolerated, and what we mean by this is you will be aware there are a number of patients on lumacaftor, ivacaftor who have adverse effects related to lung problems tolerating the drug. I think it's fair to say that both of these drugs demonstrated a significant impact on FEV1, albeit one that was fairly modest compared to ivacaftor in the gating mutations. And given that we know how much clinical impact we can achieve using ivacaftor in gating mutations, the search was on to try and find something much more impactful in patients with 2 copies of F508del. And this led to what I'm calling the leap to triple combinations. Triple combinations are those which are now targeting the F508del protein and trying to make it very much more successful in terms of restoring function. But what do we mean by triple combinations, and why are 3 drugs needed? So I think the reason is very much related to the complexity of misfolding present in F508del. This is a highly complex protein, and there is more than one misfolding step present in it in the presence of this F508del mutation. So the analogy I've used in the past is whereas we might need one set of tools to try and untangle this wool and restore it to a ball of wool, we might need a completely different set of tools if actually what we want is the knitted garment. And this is what's really being utilized with triple compounds. There are 2 correctors being used with different mechanisms of action, and then a potentiator to boost the function of CFTR. So just showing the laboratory data on the impact of these drugs on CFTR, first of all using a Western blot to show the amount of mature CFTR that's produced. Band C is the fully glycosylated form of CFTR. And you can see here that F508del homozygous cells, in the absence of any of these drugs, don't form any band C mature protein. If we look through the various combinations of those triple compounds, I think you can appreciate the very significant amounts of band C protein that are produced in the presence of the triple combination. If we move next to cells which only have 1 copy of F508del, and what we've called it here is MF, that means minimal function, and that means often the class 1 mutations where no CFTR protein is made. But in any case, it means a CFTR mutation which does not respond to any of these drugs. So any impact we're seeing in the amount of CFTR produced here with these drugs is coming from the single copy of F508del. And I think you can make out just faintly here that these triple combinations are restoring band C protein even in the context of only 1 F508del mutation. Probably most of us can understand better the impact on CFTR function itself. So here is a cell-based method measuring chloride transport and looking at the impact of these 3 drugs in cells with 2 copies of F508del, where you can see approximately 80% restoration of chloride transport. Very excitingly, we see very significant restoration of chloride transport even in those cells possessing only 1 copy of F508del, and this is the data that really led to the design of the subsequent clinical trials. What I'm going to show you here is the design of 2 trials which ran in 2 different genotype populations concurrently. At the top is the population with only a single F508del and a non-responsive mutation on their other allele. And these patients for whom there was no alternative modulators were treated in a placebo-controlled fashion for 6 months. In contrast, patients with 2 copies of F508del, who in many parts of the world were then routinely being treated with dual compounds, were actually treated head-to-head with tezacaftor, ivacaftor, in a 4-week control period, as you can see here at the bottom of this slide. So in purple we have the triple compound, which comprises ivacaftor, the potentiator, which we've heard about earlier in this presentation, tezacaftor, which was one of the first generation correctors, and elexacaftor, which is the new generation corrector making up this triple compound. So let's look first at the improvements in lung function and exacerbations. At the top of these slides will be that heterozygous group with a single copy of F508del, and at the bottom the shorter trial in the homozygous population. So first of all, placebo across the bottom line here, They maintained their FEV1 during the 6 months of this study, whereas we saw a very rapid improvement in FEV1 in patients on the triple therapy of around 30 percentage points absolute. And this was accompanied by really dramatic decreases in the frequency of exacerbation. You can see here all the exacerbations, in the middle those leading to hospitalization, and on the right those treated with intravenous antibiotics. So very impactful outcomes in patients with only a single copy of F508del. You'll recall that the study design in patients homozygous for F508del was completely different. There wasn't a placebo group. The comparator group was dual combination tezacaftor-ivacaftor, and patients were all established on a run-in of this before they actually took the triple compound. So in purple, the improvements that we see in FEV1 are over and above those improvements of 3 or 4% that patients will have experienced on TES-IVA. And we can see similarly improvements of around 10% absolute percentage points. Other outcomes of interest can be seen here. So there were rapid and substantial drops in sweat chloride, improvements in the quality of life CFTR score, and improvements in body mass index in the heterozygous subjects. The short period of time really precluded collection of nutritional data in the homozygous subjects, but you can see similar, very impactful drops in sweat chloride and improvements in CFTR in the middle here. Adverse events and SAEs were collected meticulously, as you would expect, and really overall there was very little in the way of concerning adverse events. The data demonstrated that triple combination was generally safe and well tolerated in these groups. And here are the two papers. If you'd like to look at these in a little more detail, it goes into detail about the conduct of the trial, the methodology, and the outcome measures, and I think gives you a really good grounding in how these drugs are functioning. I think really encouraging for the first time to think that not only patients with 2 copies of 508del, but also those with a single copy could benefit substantially from these drugs. So it's worth us men thinking about the modulator landscape and the very big impact that these data have on our potential for treating the global population with cystic fibrosis. Prior to these data, we had ivacaftor approved in most regions of the globe as a monotherapy in patients with a single gating or in some cases residual function mutations. We also had 2 double combinations of corrector potentiator approved for patients with F508del, and in some cases for patients with a single F508del with residual function mutation. What we now have is triple combination, which was approved by the FDA in North America in 2019 for any patient with an F508del mutation. So that includes all the homozygous population and all of the compound heterozygous mutation. And what I've put here is to really highlight in gold those treatments that most people would consider the highly effective modulator treatments. These are the ones that led to more than a 10% improvement in FEV1 and to significant impacts both nutritionally and on pulmonary exacerbations, approved now in certain regions of the world for approximately 85% of people. So these data are really exciting, but those phase 3 data were obtained from patients aged 12 and above, and many of them were already adults with established disease. We're a largely pediatric audience, and I think it's certainly worth asking the question, can we achieve more with these drugs if we start earlier in life? I believe that we almost certainly can do within the lungs. I think disease is likely to be easier to prevent or delay than to reverse. And certainly in terms of permanent bronchiectasis, no matter how good a modulator treatment is, I think it's unlikely that we'll turn the clock back on this. So do we have any evidence to support this? Now, actually collecting this evidence is quite difficult. Those of you who look after children with cystic fibrosis in the clinic will know that many of them are very, very healthy these days. So if a child comes in with already normal FEV1, how do we actually measure an improvement in that? And one of the ways the community is trying to do that is by using more sensitive measures of lung function, and one of these being the lung clearance index. Now, what I'm showing here is not a lung clearance index, it's a hyperpolarized lung MRI signal, but you can see quite clearly on this that within the cystic fibrosis lung, there are patchy areas where disease is causing problems, and then other areas where the lung looks healthy. And this can be seen even in the presence of completely normal spirometry. So we're missing this type of patchy disease. What we do with lung clearance index is a tidal breathing maneuver, which aims to measure the heterogeneity of gas mixing within the airways. And we then follow a tracer gas as it is breathed out of the lungs. You can see here we're following a nitrogen decay signal as the patient is breathing 100% oxygen. There are a number of different techniques for doing this, but globally we have standardized across 3 core facilities based in London on behalf of the European CF Society, Sick Kids in Toronto on behalf of North America, and the Children's Hospital at Westmead in Sydney on behalf of Australasia. We have standardized techniques to now be able to use lung clearance index with nitrogen washout as an outcome measure in clinical trials. These are some data from a trial in 6 to 11-year-olds of lumacaftor ivacaftor, or Cambi. And you can see that the signal on the left with lung clearance index is much clearer than it is on the right with FEV1. With lung clearance index, a downward direction indicates improvement in lung health, and we can see wide separation of these groups by 6-month time period, whereas there is more overlap on the FEV1 signal. LCI has also since been used as the primary outcome in this age group for TES-IVA, so the next dual combination, and is currently being utilized in trials of triple compounds. So back to our question of can we achieve more by starting early, I think it's worth here now looking beyond the lungs and having a look at whether we have any evidence outside the lung, and we certainly do in terms of the pancreas. So here are data from the Kiwi study and the CLIMB open label extension. These were children between the ages of 3 and 5 with gating mutations who were treated with ivacaftor. And what we're measuring out on the y-axis here is fecal elastase as a measure of pancreatic exocrine function. Over at baseline, you can see all but one of these children was pancreatic insufficient. By week 24, there was substantial restoration of fecal elastase in a proportion of these, and over the long open label follow-up period, many of these children had restoration of pancreatic function, some of them, as you've probably already seen in your own clinics, leading to discontinuation of Creon enzymes. Very excitingly, there are also some registry data from the same paper as I showed you earlier, looking at endocrine function of the pancreas and the long-term impacts of ivacaftor in the frequency of registry-reported CF-related diabetes. And given we know how much this impacts to overall nutritional and pulmonary health, these may be very substantial indeed. The fact that we were able to achieve this with ivacaftor and that we now have triple therapy, which can achieve very similar, if not better benefits in 80 to 85% of the CF population, I think gives us a lot of encouragement for the future. But of course, we do need to really be sure that we collect these data properly as we move forward. So I've really focused until now on drugs which have been produced by Vertex. These are certainly the most advanced in terms of their development, and they are the only sponsor producing drugs which has them available for clinical use currently. But I'm very encouraged to see how much is coming through the drug development pipeline. And you can see here from the CF Foundation's Therapeutic Development Network pipeline graphs that a huge number of other compounds are now in phase 2 or even beyond clinical trials. These are drugs which I think are really very needed. We may find that different patients respond differently to certain types of drugs and that tolerability is different, or drug-drug interactions are different. So we're really trying to encourage the development of these drugs at the moment through our clinical trials networks. Of course, this is partially on hold at the moment in the coronavirus situation, but we very much hope that we'll be able to pick this up once things settle down. So I hope you agree this is very exciting news. However, we do have some remaining challenges. For some patients, the current modulator pipeline is not optimal, and those are the patients who don't produce any CFTR. They will need either gene or mRNA-based treatments. Some of them may respond to read-through agents which are under development, and the progress is encouraging, but really very early days. There's also a very large number of patients who have very rare mutations. These, by their very nature, are understudied and poorly understood, but these patients may respond to some existing therapies or they may respond to some future therapies, but testing them in strictly conducted clinical trials is unlikely to be appropriate, and we probably need a different approach to testing. So you can see the sorts of approaches which have been used so far to develop some of these drugs. The initial modulators which have got through to patients were tested in mutation-specific manners, using, for example, cell lines expressing different types of CFTR mutation. What we may be needing to do is to come more down to an individual basis and actually get samples from individuals with their own personal mutations. And one of the areas that has been particularly useful and looks like yielding some promise in this area is the generation of organoids from intestinal biopsies, which can then be tested in the laboratory in response to a number of chemical stimuli. There is a project currently ongoing across Europe recruiting patients with these rare mutations, growing these organoids, and then putting people from the organoids who seem to respond into clinical trials of novel investigational medicines. There are further challenges, and of course, for those of you in this country, you'll be all too aware of the global inequities in access. It took many years after the licensing of Orkambi for UK patients to be able to receive this drug, and there are still large areas of the globe where patients can't yet receive dual modulators. We're waiting to see how this will pan out in terms of licensing and reimbursement of triple modulators. I think it's also important, though, not to lose sight of the expanding and aging population. The progress to date has led to approximately 50% or more of the CF population in many parts of the world being now in adulthood. And these patients will have established disease. They're going to continue to need us to develop symptomatic therapies, for example, antibiotics, anti-inflammatories, mucolytics. And we may also need to adapt our way of working to prioritize different models of care for this older patient population. So I think in summary, really encouraged by progress with highly effective modulators. But let's not take our eye off the ball. We need still to continue to develop through our drug trials networks, alternative modulators, and also more symptomatic therapies. I'd like to really acknowledge the contribution of the trials networks, in particular the European CF Clinical Trials Network, with whom I work closely, but also the Clinical Trials Accelerator platform launched by the Cystic Fibrosis Trust across the UK. I'd like also to thank the CF Foundation and the Therapeutics Development Network. The slides I've used here were part of a longer talk which I delivered at last year's North American CF conference. And for any of you interested, that's available on video via the click through here. And I'm sorry not to be present in person with you to answer any questions, but please do get in contact with me on my email address there if there's anything that you'd like to follow up on, or any queries you might have about getting involved in CF clinical trials in the future. Thank you all very much for your attention, and I hope you enjoy the whole course.
Thank you very much, Jane, and thank you very much for sending the pre-recorded talk. Jane unfortunately couldn't join in as she's managing adults at the Brompton Hospital at the moment. So we move on, and if anybody has got any questions, they can either come back next year in April to ask Jane face-to-face, or email her, or they can tweet her.